Okay, I'm going to keep checking in on folks and admitting folks to the room as they come. But in the meantime, I do want to be respectful of everyone's time. And Wes, especially you, I deeply appreciate you being here and being willing to speak to us. So today we want to talk about pride and pandemic. We want to talk about what it looks like in our community currently with COVID rates, and also offer the opportunity for folks to ask questions for their personal needs and questions, whether it be in your work, in your personal life. But it's not very often that we as an LGBTQ community have the ability to talk to someone as incredible as Wes and get information directly from the source. So we're really hoping to be able to offer this. So Wes is the medical director of disease control at the Jefferson County Department of Health. He has a very long, very impressive resume, and we're very lucky to have him. I'm going to let him talk a little bit more about himself, but know that if you have questions, please feel free to pop them in the chat box, and we'll be answering those as we go. But to begin with, I'd like to just say thank you for being here. And Wes, if you'd like to just do an introduction of yourself and a broad statement of where are we in Alabama in general with COVID right now.
Sure. Thank you so much. I'm so glad to be able to have the opportunity to speak. As for myself, Wesley Willeford, I'm actually originally from Tennessee, moved to Alabama to do training in infectious diseases in 2017, and I've been here since. I started my role at the health department in July of 2019. Had no idea what I was walking into with COVID-19. Early on, one of my main focus had been on sexually transmitted infections and kind of destigmatization of seeking sexual health care. It's been one of the big things that we've been working on at the health department, is trying to make a more open, inclusive, and affirming environment. Since then, of course, COVID-19 has happened, and that's taken the bulk of my time. So I would like to give just a little bit of an overview of where we are with COVID-19. I'm sure all of us have followed with a lot of interest what's going on locally, nationally, internationally, and we know that COVID-19 is very much entrenched in our society at this point. I'll kind of speak on the scale of Alabama at this point. We've definitely been seeing an uptrend in the number of new cases per day over the past several days. I think some people want to blame that on increased testing, but I think it's actually an increase in the number of new cases, and I think that's a lot to do with increased mobility in the community, where people are moving around, having more interactions, seeing more people, and giving the virus more chance to spread. At least in Jefferson County, our numbers have not been quite as dramatic of some increases as have been seen in Montgomery County, but we certainly are on the upswing. It's kind of interesting around April of the first half of April of this year. We were really on the downtrend of the first hump in the course of COVID-19. But then from then on, we very slowly, very gradually began to increase our daily number of cases. For the longest, it was 20 cases per day every week, moving into 30s, 40s. And more recently, it's been into the as high as the 80s, and typically kind of averaging around 60 or so cases per day. And like I said, that's been a steady trend upwards. Certainly something that we worry about. Ultimately, the big things that I think that are the concerns about COVID-19 are its impact on persons who are over the age of 65, persons who have multiple medical conditions, and we know that the death from COVID-19 is really concentrated into persons over the age of 65. That's where we see the highest rates of death. So with that, it's been very important that we put out messaging to do everything that we can to protect our most vulnerable groups. Here in Jefferson County, we've helped to wanted to make sure that we're protecting particularly residents of long-term care facilities, just because they just hold on one second. Oh yeah, sorry. Just because they have been so adversely impacted, and then but part of that is sort of getting increased awareness among all people that we have to think about our social networks. We have to think about the people that we come in contact with. So, if someone lives at home with their parents, then, they themselves, that they could be young, perfectly healthy, but maybe come home with their parents who may have a chronic medical condition that would put them at an increased risk for having a not so good outcome from COVID-19. And so that's something that we've really been trying to push, is that it's a community responsibility, that keeping a social distance of 6 feet at minimum as often and as much as you can, wearing a facial covering when you're out in public, especially when you're near other people, and really trying to limit what you're doing outside of the home to not only protect yourself, but also to protect the people that are close to you, and the people that they come in contact who may also be vulnerable. That's the problem with COVID-19, is that it's a virus that, prior to the winter of 2019, early part of 2020, it really had never been an infectious agent in humans before. Other coronaviruses had, but not this one. And so because of that, each human that this virus comes in contact with is potentially a host who can be infected by it and spread the virus further. And that's what makes it so hard, is that we're all vulnerable to it. And so far, there's not there's no, people keep talking about herd immunity. That's not something that we're going to have anytime soon. It could happen in the future, but we really have to aid that with a viable vaccine candidate that will be able to make that a possibility. So until then, we're really left with these non-medication, non-vaccine interventions to slow the virus down. There's a potential medication that may prove to be somewhat useful for COVID-19 called remdesivir. But again, that's still being studied, and so far it's only available by IV, so you have to basically be in the hospital to get it. What we would like to see at some point is a medication that you could take by mouth, much like the medication oseltamivir, or common name is Tamiflu, for whenever a person comes down with flu. That would be an ideal situation if you had a medication that could cut it short. But until we have a vaccine or have a medication like that, I think what we're seeing right now, our day-to-day life patterns are probably going to be altered for the foreseeable future. I hope it's not too long, but I think we have some more time left with this. And, I think we all have to begin finding ways to ease into that new expectation and find ways to still maintain meaningful connections with people, still maintain a sense of purpose, and still be able to do some things that help us to feel like life is more normal than it has become. So that's sort of my summary of where things are. I'd be glad to take, if there's anything else you'd like to speak about, I'd be glad to, or I'll take any questions.
Yeah, so I do want to ask you, you talked a little bit about testing. I'm curious, do you know of any testing sites that are asking questions specifically about sexuality or gender identity?
Yeah, at this point, I'm not aware of any testing sites that are asking those questions in particular. As far as the only thing I would say is that some places, if it's part of their normal intake process that they would do otherwise, they might, but I don't off the top of my head know if a place does that at this point.
And regarding testing, who in the community do you recommend get tested right now? I know you spoke briefly to that.
Yeah. So, and that's something that's been an evolving definition. So early on, testing was incredibly limited. Like, we had so very little testing capacity that we had to, we really had to almost, ration it, so to speak, to the people who were most likely to have it, so that we could track it down quickly. Early on, people who were hospitalized were prioritized first, but now we're at a point where there's enough capacity that we're rethinking who we recommend testing. So certainly anyone who has symptoms that are concerning for COVID-19, so that could be cough, shortness of breath, fever, chills, change in sense of smell, kind of a large array of symptoms, those people should consider being tested. And then also, we're also prioritizing people who've been contacts to symptomatic people. We want to, if you say, hey, you were in close contact with someone who tested positive for COVID-19, it's recommended that you be tested at some point as well. And then Dr. Wilson, our health officer here at Jefferson County, has also made a recommendation that people who work in public-facing jobs, that they be tested periodically. just to be able to know what their status is, because unfortunately with COVID-19, there's a fairly significant proportion of people who likely may never have any symptoms at all, or there's also a fair number of people who are able to spread the virus and are not yet developing symptoms, but may go on to develop symptoms. So knowing the sooner you know what your status is with COVID, the less likely you are to spread it to anyone else. And so certainly people have a lot of contact with the public. It's beneficial to be tested with some frequency or on some basis. And that could be every couple of weeks, but the more exposure you have, probably the more testing you should do. Another group that has been, that we're beginning to coalesce around a plan is for people who work in nursing facilities. They're being tested very regularly because, of course, you don't want even one case of COVID-19 to be brought into a nursing facility just because it can have such a terrible impact on the residents who live there.
Thank you for that. So you mentioned getting tested if you've had any kind of exposure to someone else. So my question for you is around contact tracing. Can you explain what that is and how that works? And, recently our cases have skyrocketed, and yet our contact tracing is not quite where we want it to be. So can you explain a little bit about that?
Yeah. So in general, so here at the health department and also throughout Alabama. So let me make a quick distinction. So Jefferson County and Mobile County are the only two freestanding health departments in the state. So that they're ones that are not directly administered by the Alabama Department of Public Health. So we have our own revenue streams that are paid through local tax dollars. So we do operate a little bit differently, but still ultimately report to ADPH. So what we do is that under normal circumstances, we have what we call our disease control division that has a few branches. There's prevention and epidemiology, there's tuberculosis, and there's sexually transmitted infections. So prevention and epidemiology is basically everything else besides tuberculosis and sexually transmitted infections. And so normally what we do is that for various diseases, we have various contact tracing mechanisms that are in place to make sure that people are identified, get appropriate treatment, help link to care. So what we have done for our COVID-19 effort is we've repurposed a lot of those people who do contact tracing in other parts of our division, brought them into we call it the prevention and epi division, and they have been helping with that effort. The other thing that's been going on at the health department is that our clinical operations have been brought to a halt because of COVID-19, and also some struggles that we're having with personal protective equipment, being able to get enough of it. So that means that we've also had a very large workforce of healthcare workers who we have trained to do contact tracing. So with that, we've been able to surge our capacity up to about 60 people to be able to do contact tracing each day. And we've been able to keep track or keep up with all of the cases that are coming in. Of course, I'm trying to look to the future and make sure that we're going to be able to continue to be able to handle any volume that comes in. And we're trying to come up with another mechanism, potentially contracting with an outside organization to potentially hire. We'd like to see something where we could hire locally and have people come in as needed. But that's something that we're working through right now. I'm hoping to come to a conclusion on that by the end of the month. But what'll happen with contact tracing is there's two parts to contact tracing. There's case investigation and there's the contact tracing part. The contact tracing sort of becomes a catch-all for all of this. So case investigation is you call whoever's tested positive for COVID-19 and say, hey, it's the Jefferson County Department of Health. We understand that you'd had a recent positive test for COVID-19. We figure out where do they work, where have they been, who's in their household, who are their significant contacts. So that would be people that they have been within 6 feet for 15 minutes or greater. And once we determine who those contacts are, we then subsequently contact those people and say, hey, there's been you potentially have been exposed to COVID-19. We would recommend isolation, or like a 14-day self-isolation, not a quarantine in that case, but for a person to limit their activities outside of the home and to monitor themselves for if they were to develop symptoms, and also be tested, of course, if they are having any symptoms at all. And that's the idea behind that is that the sooner we're able to identify someone who has COVID-19 and have them isolate themselves, we're depriving the virus of additional hosts or additional places that it can spread and continue to spread. And so contact tracing can really shave down the number of new cases if we're able to get people kind of isolated until they're well enough that they're not shedding the virus anymore.
Thank you for that very thorough, lovely explanation. So I want to shift a little bit and talk, we're always very careful to not talk exclusively about the LGBTQ community and HIV, but it is something that's really important to us to talk about within our community. And so how is COVID impacting our HIV positive community at this time?
And so in my conversations with some of my colleagues from UAB, I think the biggest impact has been on just the way that clinic has been conducted. I think there's a lot of move over to telehealth where available. And I think otherwise it's, I think, I don't want to speak for UAB, but I think that a lot of operations have been able to continue. It's very different from what it normally is. I think that's put a lot of challenges on people because some of these systems are having to be built from the ground up. And I think even with a reliance on telehealth, there's some people who are going to be able to utilize that easily. There's some people who may not. And I'm sure that's created a lot of challenges. The other thing I'll say is that throughout the COVID-19 pandemic, so far, I think that's been one of the questions is what is the exact effect on persons living with HIV as far with COVID-19? I don't know if that's been incredibly well described thus far. There may have been something published, but I have not seen it so far. I think it serves to reason that you want to avoid COVID-19 at all costs under most circumstances, but I think that's potentially a group that could be more adversely impacted. We just don't know exactly what that looks like yet, as we're still so early on in this pandemic.
Yeah, thank you. That's a huge concern, and I mean certainly. Those living with HIV, those with compromised immune systems, they're huge groups of people, and we understand the general warnings to stay home. But I think it'll be really interesting to see the data as it becomes more available and how that's impacting those particular communities. I also want to ask about especially our Black communities and our Black communities in Alabama. It's understood nationally that it's impacting Black communities harder, but I think it's particularly hitting them harder here. Can you talk about those rates?
Yes, let me actually pull something up really quickly, because I hadn't I was looking at something the other day. Give me one moment. So I was looking yesterday. I wanted to quantify some of that. So let me just I was looking at the Alabama Department of Public Health's website just as for a notification, kind of an idea of where things are. So as of yesterday, let's see, for COVID-19 cases, not deaths, 41.17% were in Black individuals, 35.23% in white individuals, and I think 17% there was nothing was recorded. As far as the deaths, again from yesterday, deaths were 45.79% in the Black community, 48.47% for white, and 3.5% were unknown. So I guess, and I think the last part I think is important when looking at U.S. Census data that was estimated from 2019. The population breakdown is 26.8% Black or African American, 69.1% white, and 4.4% Hispanic or Latino. So based off population, there does seem to be a disproportionate impact on communities of color. And I think that's something that does bear out across the United States. And in Jefferson County, the numbers are a little more, they're fairly similar. They're essentially in line with those numbers as far as the breakdown goes. But certainly I think that there's been a greater impact for sure.
So speaking of impact, Jefferson County has been, according to recent data, it is the third most highly impacted county in the state of Alabama. And so as we move forward and we begin to reopen, and a lot of people are, I think there's the quarantine fatigue, and people want to go back to some sense of normalcy. Can you talk to us about what it looks like to go from here in terms of, for instance, the center? We're an LGBTQ youth center. We thrive on creating a space for connectivity and community. And so what does it look like for places like the center and other community spaces that thrive on togetherness? And what are your recommendations?
I think that's probably one of the biggest questions that we're all grappling with. I know one question that's coming up that we're hoping to see what it will look like about in the next week or two is schools. What are we going to do? And then we have these more persistent, larger numbers of people gathered together, and it is challenging. I think one of the things that what I can see is the nearest term solutions is whenever gatherings are conducted. I think it's going to be dependent on who's there and making sure that we're trying to protect people who may be vulnerable as much as possible. But also, kind of the core tenets of a gathering, I think, have to be smaller group size, adequate space between participants, the use of facial coverings on all participants who can tolerate it, and really making sure that everything is done in the environment of the gathering to make it feasible. I really worry about large gatherings of, we've a lot of numbers have been thrown around before, 50, 100, 1,000. Certainly above 50, I think the gatherings are incredibly risky. And it's not that, sort of the problem of these large gatherings is it's sort of like the analogy of the chain. It's only as good as the weakest link. And if you have people not everyone participating the way they should, a large gathering, if people get very close together, spend a lot of time in each other's space, not wearing facial coverings, it only takes one person with COVID-19 to spread to a lot of other people, and potentially cause a lot of infections. And of course, those people then go out again to their families and spread the infection further. So that's why I say that events like that just has to be an eye towards small, manageable groups, and making sure that if someone is actively ill, that they're asked to stay home, or maybe even have a screener in place before coming in to decrease the chance. The hard part about COVID, again, is that the notion of people who are contagious but not yet symptomatic, or the people who truly are asymptomatic and never will have symptoms. That's what makes it so hard, is because it's hard to account for them, because there may literally be nothing wrong that a person can perceive, but they may be infected with COVID. And that's why we have to lean on the distancing, the facial coverings, and really try to keep those group numbers as low as possible.
Thank you. I know that's the question of the hour, and it's a hard question to answer, of when can we open and what does that look like? But thank you for starting to answer that. So I want to open up the floor for anyone who may want to unmute themselves and ask a question themselves. I want to give you all access to talk directly. So I'm going to just unmute everyone, so warning. If you have any questions, you're welcome to pop in. I do have one more really important question for you, which is something that I'm not sure everyone is aware of, is that there are different types of testing available. And so wondering if you can speak to the nasal swab versus the brain tickle, as we called it, and speak about that. And then also if you can talk about the two types of actual tests you can get and the efficacy of both.
Sure. So I'll start off with the nasal swab versus the brain tickle. So early on, the brain tickle, or we got nasopharyngeal swab, was really the what we were using most commonly. It was thought to have the highest yield. And basically, you go very deep back into the nose. It's quite uncomfortable. We joke in our clinic that if a patient doesn't recoil or try to hit you, you didn't go far enough. And because that's the truth. It's not really meant to be glib, but it is something that we have discovered that it is a huge barrier to people being retested. And I totally understand that, because it's not a pleasant procedure. And the FEMA had actually produced a guideline back in April, I think, that endorsed nasal collection. So instead of going very deep into the nasal cavity, you actually just go a little ways into the nose. You're really just using a swab to make a few twists and turns on both sides, and that can actually be done by self-collection. So, no worry about someone pushing too hard, or no worry about too much pressure or not being comfortable. It can be driven by the patient, but more importantly, it can allow for more social distancing. So because a person can self-collect, you don't have to have some of the more intense personal protective equipment that we're very short on. So I think that is really and here in Jefferson County, we have endorsed the nasal collection strategy because we feel like it will yield just as good of results as the nasopharyngeal sampling method. As far as the test types, there are really two main tests that are used right now. One is called the PCR, polymerase chain reaction. And it's a type of test that basically detects the genetic material of the virus or whatever you're looking for. It's very good at picking up the virus. The problem with it is it's better at diagnostics than it is as a test of cure. Sometimes we run into an issue where a person may have a positive test for weeks after they have been ill or were initially diagnosed, and it oftentimes is picking up debris of the virus more than it's picking up live virus. So that's something that causes problems from time to time. The other thing is called an antibody test, and basically it's a test to see if your body has made some type of immune response to the virus. The problem with those is they're not that great for diagnosing you right when you have it, because the immune response is something that takes a little bit of time to develop. So by the time you've detected an immune response, you're most likely already over the virus. So the use of that is if we go back, if we do large testing at some point to determine, okay, how many people, we can make an estimate of how many people may have had the virus by using a test like that. But as far as trying to diagnose, is this what's going on right now? The antibody test is not something that we want to go with.
We have a question in the chat box from Matt that says, thanks for the great info, learning a lot. Regarding contact tracing, how does privacy affect contact tracing and investigation?
So part of that, so I guess the way I'd answer that is that the privacy in contact tracing is paramount. So for instance, let's say I were to call someone and say, you've been named as a contact to COVID-19. The first question we get almost invariably is like, well, who was I in contact with? We generally will never disclose that unless, obviously sometimes it's like if for some reason we get someone in the same household that they find out that way, but we are not going to disclose who that contact is as a means to protect whoever's tested positive. And one of the other things that I think is important is, I think as far as security, if anyone ever calls you claiming to be from the health department, the most they will ever ask you is to confirm your name and date of birth. They're not going to ask you for personal information like credit card numbers, social security numbers, anything that could be used to impact your identity in any meaningful way. Really, it's just so that we're contacting you to let you know that the exposure has occurred and give you instruction on what to do. Again, we're not going to, we will never ask you for information that's potentially dangerous. And also too, if you need to confirm that it's actually the health department, we're more than happy to have you call our main number and get in contact with contact with someone so that we can confirm that it is indeed us. Because again, we're not out to, we don't want to be in any way confused with someone who may be engaging in fraudulent activity. I hope that answered the question.
Thank you. Does anyone else have a question that they'd like to either enter in the chat box or unmute themselves and ask? I'm really curious. We've talked a lot about an inevitable second wave, maybe possible second shutdown. Can you talk about forecasting into fall?
Yeah, so I would say that the second wave it's more of a I would say it's more of a second peak of the first wave, because the second wave would imply that we had gotten down to a level of almost no cases per day, and unfortunately we didn't quite hit that. We sort of pushed down the number of cases with the shutdowns that happened, but then once that was lifted, we've seen a fairly steady increase since then. The shutdown is an interesting thing and a very difficult question. I think that's probably something that I think we're going to be hard pressed to see something like that again, just because I think that the kind of the political winds right now are such that there'd be tremendous resistance to it. And it's been a hard thing for us because, obviously the health department, we understand that a functioning economy is also important, but at the same time, we have to preserve lives and do our best to take care of everyone. And we've had issues locally just because people have not been wanting to wear facial coverings quite as reliably, and not really wanting to follow the advice to avoid something like that happening again. I would say if I had to peer into the future, I think it's not very likely that we'll see another shutdown situation like we saw in the spring, but it's hard to know with exact certainty going into the future.
Thank you. That's we're recording this, and so this is your official statement on us not shutting down. So I'm taking that from you. I think my only other final question is that as we move forward, a lot of data has changed, and we're still learning so much about COVID and how it impacts us. But there's a huge push now for face masks as opposed to the surface contact. Can you tell us a little bit about moving forward, how we can protect ourselves, and especially people who are immunocompromised, what we should be doing and thinking about with face masks versus other protective measures that we can all take?
Sure. So I think early on, it was. I think that the mentality is that this is a new virus. We'll make assumptions based on what we know about for other viruses similar to it, and we definitely threw the kitchen sink at it. And I know that early on there was a lot of talk about surface cleaning, multiple surface cleanings throughout the day, and probably the virus does not do as good of a job of transmitting off of surfaces as we had initially thought. It's still possible, but it's probably not the bulk of the way that it transmits. And so because of that, that's something that, it's still important to wash your hands with soap and water or an alcohol-based hand gel. And it's important to use good personal hygiene. But probably the bigger amount of spread that we're going to see from the virus is from those droplets that we, as we breathe, cough, or sneeze. I think that's the way that we're going to see spread of the virus occur. So where the facial coverings really come into play is that the virus is, as we know, it's fairly common in the community right now. The idea being is that, so if everyone's wearing a facial covering, the hope is that facial covering is going to make it very difficult for those viral droplets to reach other people. It will not be perfect. The masks or the facial coverings made of cloth are certainly not going to be 100% foolproof, but they are going to make it much harder on the virus to successfully get from one person to the next. And that's the hope is that if enough people do that, the virus is going to be so inconvenienced by this action and so inhibited in transmitting that we will actually see some dropping numbers. And so that's why we've been pushing the facial coverings. Is at the moment it really is the easiest tool that we have to implement, and also probably one of the most effective. So that it really all has to do with interrupting the way the virus transmits from one person to the next.
Thank you. I feel like you have, in 35 minutes, done the most thorough review of COVID in Jefferson County, Alabama. So I really appreciate you. I think my final comment I just want to make really quickly is so many people talk about Pride being canceled, right, in our community and not having Pride. And while that may be the case that we're not having actual Pride events, we can still absolutely have pride as a community and have pride in ourselves and our health and taking care of one another. And we've historically thrived on building community. And so right now, the best thing we can possibly do is take care of one another, wear facial coverings. When we're quarantining very, very intentionally and carefully, and when we're out and about, making sure that we're around other people that have also been maybe quarantining, for those who have compromised immune systems, for people living with HIV, for those in our community who know that they may be at higher risk. Reaching out, asking these questions, making sure that we're all educating ourselves and one another. Pride is not canceled. Pride started as a protest, and that is certainly something that we are all working through as a community, and fighting and advocating for Black Lives Matter and for LGBTQ lives. So I want to thank you for your time today and for advocating for our community and the entire Jefferson County, for us to all be healthy and well. So thank you so much.
For letting me speak. I really appreciate it. And,
Yeah.
you know, I just have to say that this has all been very, I think it's challenging for everyone. Like, you know, and I would say even here in public health, we're not immune to sort of these challenges. And I have to just say that, you know, I think there's nothing we would all like more than to see this virus go away. But I think we all have to be clear-eyed about what will happen, and we have to know that there's a lot of work yet to be done. And you know, I just want to thank everyone in the community for doing your part and trying to prevent the spread of COVID-19. And you know, if you know, I would say as you see your friends, you talk to people, you know, if there's something that's going on that maybe they're not doing as well as they should, especially when it comes to facial coverings and keeping their distance, I think maybe saying something, and you know, out of a place of caring, I think that's the best thing that we can do as a community to sort of work together and really try to get on the other side of this.
Thank you so much. You said that so perfectly. So happy Pride, everyone. Let's all go take care of ourselves, wash our hands, support Black people, you know, all the things. So thank you all so much for your time. And Wes, thank you. You're brilliant and incredible, and your time means so much to us. So hopefully we can do this again, maybe in the fall. We'll talk about where we are in the fall as opposed to where we are today. So thank you, and I hope you all have a wonderful rest of your day.
Thank you all. To stay safe.
Thanks.